Shelby Brantley, body and face plastic surgery, Flowood, Mississippi. Today, the question surrounds mastopexy, or breast lift, with or without an implant. So essentially a breast reduction or breast lift is tightening the skin such that it serves as a brassiere to help elevate droopy breast tissue. When I assess a patient's breast, I look to see where their nipple is relative to the inframammary fold. So the inframammary fold is this crease at the bottom of your breast where the breast quits being the breast and the tummy starts being the tummy. I put my finger under the breast and then I feel my finger through the breast. And the nipple's position relative to that mark tells me the degree of droop or ptosis that they have. It's not the can you hold a pencil under it test. It gives me an idea. So if the nipple is above that mark and yet it looks like some laxity of the skin, that's called pseudo or false ptosis or false droop. So in a patient like that, then what they would need would be an implant that would, if you will, revolumize their breast and give the appearance that the nipple really is more centered up on it and add volume back. If the nipple is at the level of the fold or the inframammary crease, then that's called grade 1 ptosis. That's the mildest. And so you have two options there. One would be to put an implant on top of the muscle, and usually if I'm going to put an implant on top of the muscle, I'm going to use a gel implant because it's going to feel more natural and be softer. Okay. So a woman has to accept that, okay, my breast is going to be a little bit lower on the chest wall, but it's going to be revolumized and I don't have to take on the additional incisional scars that would be associated with a lift. The next, after grade 1, it would be grade 2. That's a nipple areola that's still forward facing. It's a little bit lower than sitting at the fold, but it's not at the very bottom. So in a patient like that, then you may be able to get by with a lift that doesn't involve using what's called a wise pattern. Okay, so you might be able to make just an incision around the areola, which is termed a Benelli or a donut mastopexy, or sometimes you have to do what I call a balloon on a string or a lollipop incision. So that would be an incision that goes around the areola and then a short vertical scar or an element to it. And then grade 3 ptosis would be where the nipple's at the very bottom of the breast, but it's still forward facing. And in those patients, it's going to require an incision that goes around the areola vertically for 2 inches and then across at least a portion of the inframammary fold. And then grade 4 is where the nipple's looking straight at the floor. And like I said, clearly with grade 3s and 4s, then you're talking what's called a wise pattern or an anchor type incision. Those incisions are closed with multiple layers of dissolvable stitches, and what you end up with is a scar that goes around the areola vertically for 2 inches and across the bottom of the breast. You don't want to have suture trackage, so there's no stitches on the outside. And like I said, what it does, it serves as a brassiere to help hold the breast tissue up. There's some suturing or elevation of the breast tissue as well. But if you look at those women over a long period of time, what happens is the skin relaxes and the majority of the projection is in the bottom half of their breast mound, okay? They don't have this upper pole fullness that most women desire that, you know, a bra or a push-up type bra allows them to achieve. And so most of them look at it and say, okay, well, how would I get that upper pole fullness and I didn't have to wear a bra to get it? That's where an implant plays a big role. And so what you do is the pec major muscle is a big muscle that comes across your breast like this. It's arising from the 6th and 7th rib and from the breastbone or the sternum. And like I said, it's a big fan-shaped muscle that inserts on your humerus or your arm. And it's your bench press or push-up muscle. So what you do is you place the top part of that implant under the muscle, and the muscle helps to support and keep that implant up here to give you that upper pole fullness, and you reposition the patient's breast mound such that it's centered up on that implant. And that's why most of the time I encourage patients to give consideration of that. I've been doing this for 32 years. Some surgeons break that up into 2 operations where they'll either do the lift and then go back several months later and put an implant in, or they'll put an implant in and then several weeks or months later do the lift portion of the operation. I don't see the necessity to separate that into 2 operations. And basically it's a complex operation, You want someone that experience, and one has to recognize that just like any other part of your body, there's going to continue to be the aging process. And although we like to think we're all fairly homogeneous, some people's skin's more stretchy than others. They may have stretch marks in the skin of the breast that can affect their ability to hold things up. And so modification or tweaking or enhancing may be required down the road. But that's something that you certainly most likely we should be. So that's a little tutorial on the mastopexy.